Before you listen to this voiceover, make sure that you have already either lectured on or listened to shock, as the systemic inflammatory response syndrome or multiple organ dysfunction syndrome are results of patients who have experienced some degree of shock. So again, if you're getting ready to listen to this voiceover, make sure that you have already reviewed or listened to shock. Systemic inflammatory response syndrome is a systemic inflammatory response to a variety of insults, including infection, which is also referred to as sepsis, ischemia, infarction, and injury. Generalized inflammation in organs remote from initial insult characterizes SIRS. A systemic inflammatory response can be triggered by many different mechanisms, including mechanical tissue trauma, burns, crush injuries, surgical procedures, abscess formation, intra-abdominal extremities, ischemia or necrotic tissue, which could be pancreatitis, vascular disease, MI, microbial invasion or bacterial, viruses, fungi, parasites, endotoxin release, that's a gram-negative, gram-positive bacteria, global perfusion deficits, post-cardiac resuscitation, shock states, and then regional perfusion deficits, distal perfusion deficits. These triggers are mentioned on the previous slide. Mechanical tissue trauma, so that could be burns, crush injuries, or surgical procedures. Abscess formation, that could be intra-abdominal or even in the extremities. Ischemic or necrotic tissue, that could be pancreatitis, vascular disease, or myocardial infarction. Triggers could also include, as previously mentioned, microbial invasion. That can be bacterial, virus, or fungi, endotoxin release, global perfusion deficits, regional perfusion deficits. Multiple organ dysfunction syndrome is the failure of two or more organ systems in an acutely ill patient, such that homeostasis cannot be maintained without intervention. MODS results from SIRS. These two syndromes represent the end of a continuum. Transition from SIRS to MODS does not occur in a clear-cut manner. This image here demonstrates, kind of shows the relationship of shock, SIRS, and MODS. So all of these start in a shock-like state, which we've talked about on previous voiceovers. So cardiogenic shock, hypovolemic, distributive, obstructive shocks. This then turns into systemic inflammatory response, or SIRS. Then SIRS affects or turns into multiple organ dysfunction, and then all the different dysfunctions are listed, which we've talked about previously in a previous voiceover. So cardiovascular, lung, gastrointestinal, liver, CNS, renal, or skin dysfunction. When the inflammatory response is activated, consequences include the release of mediators, direct damage to the endothelium, and hypermetabolism. In addition, vascular permeability increases. This allows mediators and protein to leak into the endothelium and into the interstitial space. White blood cells begin to digest the foreign debris, and the coagulation cascade is activated. Hypotension, decreased perfusion, microemboli, and distributed or shunted blood flow eventually compromise organ function. Again, this is just continued from the previous slide, talking about hypotension, decreased perfusion, formation of microemboli. Hypotension and decreased perfusion, microemboli, and redistributed or shunted blood flow eventually compromise organ perfusion. The respiratory system is often the first system to show signs of dysfunction in SIRS and MODS. The inflammatory mediators have a direct effect on the pulmonary vasculature. The endothelium damage from the release of inflammatory mediators causes increased capillary permeability. This causes movement from fluid from the pulmonary vasculature into the pulmonary interstitial space. The fluid then moves to the alveoli, causing alveolar edema. This creates an increase in shunt, so blood flow from the lungs to blood flow to the lungs that does not participate in gas exchange. That's what shunting is defined as. And worsening VQ mismatch. The end result is ARDS, and we've talked about ARDS in our respiratory section. The patients with ARDS need aggressive pulmonary management and mechanical ventilation. So the cardiovascular system, cardiovascular changes include myocardial depression and massive vasodilation, resulting in decreased systemic vascular resistance and decrease in blood pressure. Baroreceptors respond to enhanced cardiac output. Your baroreceptors would be your inotropic and chronotropic. Your inotropic is an increased force of contraction, whereas your chronotropic increases the heart rate. So that response enhances cardiac output. To compensate for hypotension, cardiac output increases with an increase in heart rate and stroke volume. Increases in capillary permeability cause a shift of albumin and fluid out of the vascular space, further reducing venous return and thus the preload. Neurologic dysfunction commonly presents as mental status changes related to hypoxemia, inflammatory mediators, or impaired perfusion. These acute changes can be an early sign of SIRS or MODS. The patient may become confused or agitated, even combated or disoriented, lethargic, or comatose. These mental status changes may be due to hypoxemia and the effects of impaired perfusion. The renal system effects are acute kidney injury. This is decreased perfusion to the kidneys, which activates the SNS and the renin-angiotensin system. The stimulation of renin-angiotensin system results in systemic vasoconstriction and aldosterone-mediated sodium and water reabsorption. So careful monitoring for these patients is important. Again, their net volume we're looking at, because that's going to be an indicator of their kidneys unable to process some of the fluids. In all patients that have any level of shock, again, the first sign is low blood pressure. So these patients are always fluid challenged, and because of that, in their the acute kidney injury, they tend to retain a lot of fluid, which puts more pressure on their vasculature. So again, acute continuous renal replacement therapy is often recommended for these patients to help get rid of waste and help with their metabolic function. I've already talked about our GI system, but again, with decreased perfusion, we can have a decrease in motility. They can have abdominal distension and risk for paralytic ileus. Because of the decreased perfusion, they're at higher risk for ulceration and GI bleeding. There is also potential for bacterial translocation. More with our pathophysiology with SIRS and MODS, these patients become in a hypermetabolic state, hyperglycemia or hypoglycemia, insulin resistance. They can have a catabolic state, liver dysfunction, and lactic acidosis. DIC may result from dysfunction of the coagulation system. DIC causes simultaneous microvascular clotting and bleeding, and because of the depletion of the clotting factor and platelets, and in addition to excessive fibrinolysis. So that's more on DIC, which is in a separate voiceover, but basically that's the process that's happening: microvascular clotting and bleeding, depletion of clotting factors, platelets, and also combination of excessive fibrinolysis. Electrolyte imbalances are common and a result from the hormonal and metabolic changes and fluid shifts. Also, the metabolic acidosis results from impaired tissue perfusion, hypoxia, and a shift to anaerobic metabolism, which then causes an increase in lactic acids. If a patient develops MODS, the prognosis is poor. The mortality rates are 70 to 80% when 3 or more organ systems fail. Again, the statistics and survival improves if it's detected early and goal-directed therapy. So obviously the goal is to prevent the progress of it in rapid assessment, early detection, and early intervention for a patient that's suffering from sepsis or SIRS, even just in shock in general before it progresses into this state. The prognosis for the patients with MODS is poor. We talked about that the mortality rate is 70 to 80% when 3 or more organ systems fail. The most common cause of death continues to be sepsis. Survival improves with early goal-directed therapy. Therefore, the most important goal is to prevent prognosis into SIRS and MODS, and then to MODS, and then furthermore into DIC. There's a table in the Lewis book on 66-10, and it is manifestations and management of SIRS and MODS. It gives per system: respiratory, cardiovascular, central nervous system, endocrine, renal, gastrointestinal, hepatic, and hematologic. It gives the manifestations, and then it talks about the management of each of those different areas. So I'm going to refer you to that table to just review and be familiar with. I think it's more important to kind of focus on the different shocks and sepsis itself and just have an understanding that it can develop into SIRS and MODS. Our goal in treatment is to prevent the continued progress of organ failure. So when we are seeing these patients, we want to get early detection, early screening done. A lot of those protocols are in place in the hospital setting, but then doing your part as the nurse to make sure that they get recognized and initiated early on. Again, like we talked about the different stages of shock, if we can get it detected early in those initial stages before it progresses, the outcome for the patient improves, and the likelihood that they'll survive it increases. Aggressive infection control strategies are essential to decrease the risk of hospital-acquired infections. Prevention and treatment of infection is important. Strict asepsis, and assess the need for invasive lines. Again, anything that isn't necessary for the patient, whether it be urinary catheters, IVs, central lines, endotracheal tubes, anything that can cause or introduce infection for those patients, we want to minimize and remove quickly. There's strict protocols in place within the hospital setting for IV lines. I know some places use Kuros caps. IV tubing needs to be changed per hospital protocol, usually every 3 days. We need to be vigilant about keeping those sites clean and making sure we're using good hand hygiene, especially from patient to patient, just to be cautious to help prevent any potential infection. Hypoxemia frequently occurs in patients with SIRS and MODS. These patients have greater oxygen needs and have a decreased supply, so the supply and demand are not equivalent. Interventions that decrease O2 demands and increase O2 delivery are essential. So making sure the patient is sedated and mechanically ventilated. Pain medications are administered so that the patient can rest and have a decrease in oxygen demand. Will help with the oxygen delivery and optimize and be optimized by using individual tidal volume with positive end expiratory pressure, or PEEP. Those are the main things that we can do metabolically to assist the patient in their recovery, just so that their metabolic needs and their body's demand needs are low. So keeping them sedated, keeping them mechanically ventilated, controlling their vent settings, increasing their PEEP, and pain medications and rest. These patients that are suffering from SIRS and MODS, their energy expenditure is often increased metabolically to 1.5 to 2 times their normal state. So these patients can be pretty malnourished, and then they continue to suffer in their recovery and their metabolic needs. So early nutrition is really important to help preserve any organ function, especially when it comes to the GI and the liver. It's important to have an increase in protein calorie to avoid malnutrition. So to kind of complete this section on SIRS and MODS, we talked about throughout this PowerPoint what it is, why it happens. It usually happens after the state of shock or sepsis, and how we can try to prevent it. If we can use good hand hygiene and aseptic technique, and taking items away from the patient as ordered by the doctor, but advocating for them to get Foley catheters out, to remove central line access, to avoid complications or infections related to those lines that aren't being used. And then to detect it early, so to be aware of your patient condition, know what to look for, what to assess for, and then early nutrition therapy does help with the patient outcomes as well. So these areas are, the last of it is to support any of the failing organs that are happening. So the failing organ, respiratory-wise, would be if the patient goes into ARDS. Again, we've talked about that in respiratory. Our goal is to give aggressive oxygen therapy and mechanical ventilation. Remember that our volume isn't the focus for ARDS. It's smaller volume, larger PEEP or positive end expiratory pressures, and high levels of oxygen therapy. And then DIC, which is in another PowerPoint, but give appropriate blood products and coagulation therapies is needed to prevent complications related to DIC. Renal failure, these patients acutely, we can advocate looking at their net volume and their I's and O's, and communicate with their providers early on. I know in my experience, oftentimes I would have to make the recommendation to the intensivist when I started to see that net volume increase and the patient's condition continue to fail. Sometimes we could get continuous renal replacement therapy or get nephrology involved pretty early. Sometimes we did it kind of preventatively, and we would see good patient outcomes. So just knowing that we have to support those organs in attempt to improve the patient outcomes. If they continue to fail and these things continue to not show improvement, again, if 3 or more organs are failing, their morbidity is 70 to 80%. So then we would anticipate withdrawing of life support and starting the end of life care for these types of patients. Again, this is going to be provider focused. The provider is going to kind of take this one on. So our role is to anticipate that and to prepare the families for that potential if their loved one's not responding to treatment, or if we have not been able to successfully get them out of the progressive stages of SIRS and MODS.